Good afternoon, everyone. So we'll dwell into the comprehensive genomic profiling and see what we can learn from that. In fact, I was also learning a bit when I was trying to prepare for this talk. Cancer is, quickly, I'll run through the first few initial important points in the genomics. And cancer is a disease of the genome. As we know, chromosome has the genes, and the genes are affected by the carcinogens, radiation, and mistakes in DNA copying. And genome is the complete set of genes or genetic material present in a cell or organism. Only a subset of the genes are relevant in cancer. When we look at the human genome, only 1.5% of the genes are actually important for cancer. And a few hundred are known to be involved. Of the thousands of genes, about 22,000 of them, only a few hundred are known to be involved in cancer. And so this is how it happens. The altered genes lead to altered proteins, and the altered proteins make the pathways altered, and finally uncontrolled growth and cancer occur. And this is how so many of the are identified, and we have targeted agents affecting them. The number of targeted therapeutics are rising. There was a talk which I gave in around 2016-17, and then it was a prediction that we have by 2025, so many of the compounds can be identified, and that is true indeed, and we are there. So the revolution in cancer care has started with the lung cancer, I should say. Initially, it was a one drug fits all, and then one patient group, one biomarker, one drug, and finally you have, if we identify a small center patient is of a different color, and in this whole cartoon, and one patient, one tumor profile, and more options. That is where we are. So advances in cancer biology is driving the future where cancer care is becoming truly personalized. One patient, one tumor profile, and more options. The lung is the lead indication in this profiling, and these are all the mutations which are identified in the tumors and the drugs which can affect them. So the evolution of molecular testing, it has so many of these abnormalities. This is the normal gene, copy number alterations, substitutions, insertions and deletions, rearrangements. So many of them. Now, genomic sequencing evolution is like this. We had the IHC, the FISH, the PCR. The Sanger sequencing is the first generation sequencing, NGS-based hotspot testing, comprehensive genomic profiling, and whole genome sequencing. So when we have the DNA, we have the FISH test, the PCR test, and the genomic sequencing. Then the DNA going to transcription, causing the mRNA transcription, and then we have the real-time PCR. The RT-PCR is needed for the RNA. The molecular pathologists can enlighten us as we go on into the discussion. And finally, when it comes to the protein level, it is the IHC which identifies the pathology. So a routine single marker molecular test is category 1, where there are so many of these abnormalities present in the gene, but only of 6 or 7 of them, only one is found, the others are all missed. And in category 2, a couple of them, or 2 or 3 may be found, but many are still missed. And finally, so all these companion diagnostics have their limitations, like the IHC, FISH, and hotspot panels. They all can miss some of them. And in the NGS, commonly we all say, when we talk about lung cancer, we say NGS. That's not the word. Probably we should start using CGP as the word. That's actually some learning for me also. We always call NGS, but then NGS includes all these, the genome sequencing, the exome sequencing, and the targeted panels. It's the targeted panels that we are all exposed to, but then we should be looking at a comprehensive panel. And do not provide information on the regions outside of which we ask for this testing. So it should have a comprehensive genomic panel. That's what has been happening by the foundation medicine in the beginning. And you see what are all abnormalities are there are all found actually in this comprehensive panel. Now, hotspot versus comprehensive genomic panel profiling is what we should know. If we see all these exons, 1, 2, 3, and 4, one exon is where the hotspot is identified.
Excuse me,
and
sir.
Then
it's a panel discussion. Maybe ask.
Yeah, I'm just coming to that because I also felt that we should have a little brief of this before we get into the questions. I have a half an hour, I suppose, and then we'll run through. We'll finish in time. That's what is the difference between CGP and hotspot. Right. Now we come to the case. Right. We have a 59-year-old female, stage 4 NSCLC treatment naive. Tissue NGS panel and liquid biopsy, Gordon 360 were ordered. Tissue NGS was negative. Gordon 360 is nothing but liquid biopsy also included. Identified an EML for ALK fusion and a surprising ALK point mutation T1151M. This patient is treatment naive and still had the mutation. So tissue fish only showed ALK fusion. Patient was treated with alectinib. Patient is responding well to treatment. So if we hadn't ordered the comprehensive genomic panel, the ALK fusion and resistance SNV would have been missed, leading to suboptimal patient care. So this is how it is. The EML4 ALK fusion had this alectinib, brigatinib, and lorlatinib as indication, and that's how the patient responded to alectinib. Now, where do we see the utility of CGP versus hotspot in NSCLC? Can I have, I think one by one we can go ahead. Anyone who can answer the question in the panel can take it up.
Yeah. So it's a broader panel as compared to hotspot NGS. Hotspot NGS basically uses few genes, and within those genes, hotspots, that is the recurrent genetic alterations, are covered. Whereas CGP looks at a larger, like you showed Garden 360, that looks at 74 genes or 740 genes. Foundation one looks at around 324 genes, and it covers a broader aspect. Apart from single nucleotide variations, insertion, deletions, it also looks at genetic rearrangements. It looks at copy number alterations. The test also gives HRD, tumor mutation burden, and microsatellite instability also. So utility of CGP is when you are looking at a larger aspect, larger genetic alterations to be covered in the same tissue. The cost effect costly test because it gives you a larger picture from the same amount of DNA that goes in as compared to the hotspot NGS that is there.
Sure.
Yeah. So as we go ahead, CGP, utility of CGP would be more and more as compared to the regular hotspot NGS that we are doing at.
Exactly. Anyone else? Any other opinion? No.
I personally do hotspot NGS, and as your case says, in such cases, if the disease progress sooner, then I go for comprehensive.
Right. Yeah. So the molecular biologist here in the panel, any one of them, all are clinicians.
Molecular, yeah, please.
Yeah, please. Can you enlighten us a little more on the hotspot versus CGP from your angle?
So basically, as Dr. Sushant highlighted, hotspot means few known regions.
Right.
And CGP means comprehensively whatever biomarkers are there, we want to get that information. Each has its own advantages. Each has its own disadvantages. So we have to weigh. In terms of hotspot availability is more you can do at a cheaper cost, and the drugs are commonly available. CGP, yes, you can get a lot of information, a lot of biomarkers, but whether you require that for your treatment purposes, whether those drugs are available in your treatment algorithm at all.
If I can ask you a question at this point, supposing we only ask for an EGFR
Yeah.
or an ALK, where are we? We are at the hotspot or CGP, and what is the difference there?
So usually doing it by an NGS or even hotspot testing is very well sufficient if your panel is right. If your panel is not right, problems in any of the assays, it might be a hotspot panel or any other panel. Typically, CGP is a very well designed assays. It gives a broader net and allows you to pick up all mutations, fusions, CNVs, LOH, TMB. So all biomarkers are available on your table when you are treating a call. So you might not need them at diagnosis in the first line. You might want to try it out at the post-treatment level, post-treatment as well. So depending upon the time point, the drug availability and the need, cost, all those factors you take into account before.
There is an oncopathologist here. Pathology, anybody? Okay. Okay, so probably you can answer that. The problem here is the tissue. Always we have tissue as the issue.
Yes.
And so if we ask for a hotspot and then we look at a CGP, probably we would be missing out. Now, how can the pathologist guide the clinician as far as the tissue is concerned?
Yeah, so tissue is always an issue when lung biopsies are concerned, because these biopsies are small. They are generally 2-3 cores that are there. Okay, it's not like a large resection specimens that generally come for other tumors that are there. So as per the recommendations that have been given, the tissue, whatever number of cores are there, those need to be divided into 2 blocks by the pathology department or the oncopathology department. One block is taken up for the HNE section, diagnosis, IHC, and the other block is preserved for molecular testings. Okay. So both CGP and hotspot NGS are equal in part once the DNA extracted is good in quantity and quality.
Sure.
So in your case over here, that the NGS, the initial NGS missed the ALK. It has been shown, whereas
Okay.
the Garden 360 got it. So we need to see whether that initial NGS was made, the panel was made to catch ALK rearrangement or not.
Right. So quite commonly, one of the clinicians can answer, what happens when we actually submit a specimen for the pathologist? We generally wait for a diagnosis and then ask for a panel. Yes or no? And that is where the whole problem is coming. And if we actually we are able to go through all the slides, then we'll know. And on a clinical radiological basis, you make a diagnosis of lung cancer and you are alerted for a CGP is what is going to be the message. So in that sense, is there an alert system which has to be developed for the pathologist to alert the clinician and say, this is what you ask for? Is that possible? Where are we in India for that matter? Yes, please. Yes, please.
Suppose you get PDL1 hypermutation, 200 mutations, but without a histopathology report. What is the clinical impression? I just want to ask the panel. Suppose you do a PDL1 expression biomarker study, you get a hypermutation of 200 mutations per slide. And without any histopathology report, non-small cell, adenose, squamous, large cell, whatever. So what is your treatment approach in that situation?
I think clinicians can.
The PDL1 is positive and the other mark.
Not able to hear.
If the PDL1 is positive and there are no other targetable mutations, then definitely we will go for immunotherapy plus chemotherapy. But if concomitantly, if there is EGFR mutation or ALK mutation, then definitely we need to hit the target, not the anti-PD-L1 drug. Yeah.
So
Expression can be hypermutated.
Yeah.
Can I, can I just,
We need to have a biopsy.
yeah, just a second,
No,
Prashanjit sir.
biopsy. Without biopsy, we can't get.
Can I just chip in a moment, Prashanjit sir?
Right.
I think for when you are discussing PDL1 and when we are discussing immunotherapy based on PDL1, we need the biopsy in the first place because we cannot get PDL1 status from liquid biopsy
Liquid
because it is
biopsy.
an immunohistochemical test. So unless we have a biopsy, we cannot get a PDL1 test. So that's the
yeah, so PDL1 is an IHC. So I mean, while the IHC is evaluated, you will be getting the diagnosis also of what cancer it is.
So Dr. Prasenjit,
But I think, I mean, biopsy is a must. Yeah. Yes. Yes.
one second, somebody wants to say something. Yes.
Yes. Hi. Hello. How are you? I'm Chanchal. Can you see?
Chanchal Goswami, your old friend.
Yeah, Chanchal,
There.
go ahead.
I was listening to the discussion. I think the crux of the story is before we do anything, we need to have a morphological diagnosis.
Yes.
That's the most important. And to decide whether it's a non-small cell, squamous, adeno, blah, 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 you need the immunohistocytochemistries. And also you need to know small cell or non-small cell. And then comes your NGS and CGP. By far, our practice is concerned because CGP is a more expensive. It takes around 3 weeks' time to come the entire report. It is preferable to do the hotspot mutations NGS because we know there are around 50 genes that will help us to start the treatment.
Again, Dr. Chanchal,
and for your recurrent tumor, I think this CGP comes handy because that's a more complicated situation.
Sure, I'll put it in the proper perspective. What Dr. Chanchal was telling is you need to have the initial diagnosis. Yes, adenocarcinomas are the ones where we actually look at the gene panel and all. Of course, some squamous cell carcinomas also are eligible for that. So between the two of them, almost 80% of the lung cancers are identified. So the point is, whenever you have a lung cancer, more so an adenocarcinoma or a squamous popping at us, we should be thinking of a comprehensive genomic panel, and the PDL1 would get covered in the comprehensive gene panel too. That's the point which is to be done. So thanks to Dr. Prasenjit, we have covered that point quite early, I should say. And this is, of course, about all the studies which show that about 69% of the patients have targetable mutations. And these are all various trials to show that it is so very useful. And then even if it is, everything else is negative, if we do I mean, there are about 70 times multiple biopsies were needed. 70% of the patients needed multiple biopsies. So to avoid multiple biopsies, the issue is what we were discussing. And so that point has been covered. And even if we have the lung cancer patients, if we do a comprehensive profiling, most of them, they get segregated into one of these. And so probably we'll find an actionable mutation. And we'll skip all the slides in the interest of slide. This is just to show that so many more percentages, 17% more EGFR, 22% more EGFR point mutations, and 35% more ALK fusions are detected if we do a comprehensive genomic panel. For us to understand and for the youngsters to understand, if we have more than 52 genes, then it is a comprehensive panel. They have to label it as such. That means all the things are covered. Less than 52, it is even called as a small panel, which is probably what we are all exposed to daily in our clinic by various of these laboratories telling us. And this is also to show that all the variants are also detected, and we'll come to the case. Is the quality of the test more important or the cost? What other factors influence your choice of an NGS test? It's mostly CGP, so most questions are actually for the molecular pathology.
Sir, in West Bengal, many of us here work in government setup, so we get patients in advanced stage, and what the maximum we can achieve is go to a hotspot. So the cost is the main issue or constraint. both with respect to the testing as well as the therapy, whether they can afford. Then only comes the question of doing the test.
Right. So cost, the properly trained personnel, the molecular biologists who can interpret all the data, and the proper equipment. All these things are necessary for a CGP, and it's still not available in-house in many places. And so development of a thing in-house will always matter a lot. That's one of the messages. Of course, the type of test we in India have not yet reached either the government or the foundation one level. So I always keep asking all these companies when they come with this so many panels, 32 gene panel, 52 gene panel, and so on. I said, how are we inferior to these so-called, is there anything that we are deficient in analyzing the data and saying that we are on par, whatever genes we have analyzed, whether it may be 50 or 60.
Yeah. So your choice of an NGS test.
The quality essentially here I understand is the company which is offering the test. How important is that?
It's very important.
Is the data being analyzed properly by all? Can we take it on the face value, or do we need to pick and choose?
So quality is paramount importance for any test that you do. So that is why you need accreditation bodies are there. So is like NABL, CAP accreditation, they kind of certify that the laboratory is doing. Even for you or us as a clinician, when we are analyzing the report, looking at the depth of sequencing, what is the VAF percentage and what coverage. So all those are QC parameters which help us read and analyze the report. So quality for that matter is very important. But in our scenario, Indian scenario is slightly different. It is not only quality, cost is also very, very important. And the access to those drugs is also very, very important. I cannot have a patient who is not having access to drug being targeted for a CGP. And so my approaches might change, even though that is available, but my approach may not be just offering CGP.
Sure. Yes, ma'am. Want to make a point? I'm trying to make a point.
Hello. In your previous slides, it was shown that NGS from NGS hotspot, there is US genome database. Do we have NGS based that database for our patient?
Okay.
Do we have that for our patients? The cancer registry is not adequate. The NGS is not adequate. And now we are talking about CGP. It is not about just copying anything from Western countries. We have to do our basic work, and then the cost and everything should be taken care. Then
Yes.
only we can go forward.
Yes, madam. I fully agree. There needs to be a database. And unless we make a starting point somewhere, the data also will not accrue. Unless we ask for the CGP or the NGS for that matter, the things won't move. And unless we clinicians are aware of the fallacies and the negative points which Dr. Saab has said, we will not be able to demand from these so-called labs which are offering us.
For that NGS, that is our primary target to fulfill, and then we can.
So one of the points that we are going to make is we need a molecular tumor board. A molecular tumor board has the clinicians, radiotherapy doctors, surgeons, even for that matter, pathologists, the molecular biologists, the geneticists, and so on. So all of them will sit down, try and find out all these variants which are occurring, and slowly over a period of time, they get standardized. But we should start asking for a comprehensive genomic panel is the message. Here, of course, in a scientific discussion, cost is important, but cost cannot be put as primary thing because the discussion will go nowhere in that case. So I skipped this slide. Oh, sorry. So this is just one more case we'll go through. I think in the interest of time, that will be the last. A 70-year-old mole. Here again, he had a PD-L1 positive initially, and then pembrolizumab and bevacizumab was given. In 1.5 months, 1.5 months time, there was a lung collapse, and liquid biopsy when it was done, metaxon 14 skipping SNV was detected, capmatinib was given, and because of partial in 5 months, due to declining renal function, the tepotinib had to be given. Patient is all right for 1 year. So that is where the CGP helps. And in this very slide, we will cover the liquid biopsy also. How important is it? Is the clinicians can answer here. How often do you ask for a liquid biopsy and versus tissue biopsy? Any opinion? Anyone, please? That the doctor next to you has to answer something. Yeah, sure.
Liquid biopsy.
The liquid biopsy, tissue biopsy, the difference and the importance. Okay.
So
Yes,
in
please.
many cases, we do not get enough tissue for sampling. For the CGP, we need a considerable amount of tissue material. So in those cases, we have to depend upon liquid biopsy. So it's not an uncommon scenario where tissue biopsy is not adequate. So of course, their liquid biopsy have to depend upon, and it's based to complement those two come in as complementary. Like
The
we
two
do
are
both.
complementary.
We
That
do
is the
both.
most important point.
Yeah.
And as far as possible, whenever, especially in progression, if the patient is not all right for a biopsy, liquid biopsy has more of importance. And there are various papers showing sometimes liquid biopsy is better, sometimes tissue biopsy is better. The both are complementary is the most important point, and we should be considering them actively.
Should do both.
Again, of course, as the other panelists were discussing, cost is an important factor here. But then this is where we are evolving.
If cost allows, we should do both. That's it.
Right. Dr. Sijit, any other point? I think we'll stop at this because in the interest of time. The important point is that we should have a comprehensive genomic panel right from the beginning in the mind, tissue biopsy, liquid biopsy, all of them to be, because they are complementary, to be kept in mind from the beginning of treatment of a lung cancer patient. That's the important message for today. Thank you, one and all.
Thank you, sir. Really, we had short of time. We started a little late, but you initiated a good discussion. We understand with the backdrop of non-small cell carcinoma is actually a best example for precise treatment.
Yes.
And the stakeholders over here, oncologists, patients, community, we all have to think about an outcome. So that way, comprehensive genomic profiling is the way forward.
It is important, and it is to be thought right from the beginning. All of us clinicians can give many examples. Only yesterday, we had a patient who had all the driver mutations negative and PDL1 positive. So we are onto that treatment. And then the comprehensive genomic panel, it can still detect some of the rarer ones, and the patient may. Thank you.
Thank you.